Welcome back to the Pathway Podcast, episode 2. My name is Nino, and today I'll be moderating a discussion with Dr. Danny Arora. Dr. Arora, how's it going?
It's going well. Thanks for having me.
Perfect. So this episode is going to be all about foot, ankle, with some focus on bunions.
Sounds good.
Just wanted to provide a quick intro of who you are and your background into orthopedic surgery and what led you to focus on foot ankle procedures.
Yeah, so I am an orthopedic surgeon. I specialize in foot and ankle surgery, primarily more minimally invasive techniques and sports medicine, arthroscopic techniques in the foot and the ankle. My journey that led me to orthopedic surgery and primarily in foot was an undergrad in athletic therapy, dealing with a lot of athletes on the side, referring my athletes to the team surgeons and the team doctors, and I decided to go that route, being at the end of the line to try to get my athletes back to their sport and to their activities. And that's how I got into med school, with the goal of getting into orthopedic surgery and playing a part in returning active people back to their sports and activities. After that, once I became an orthopedic surgeon, my first subspecialty training and fellowship was in sports medicine and arthroscopy training. And then I did a little trauma fellowship as well, which got me well versed into that field. And then I specialized into a more specific niche, which was more sports foot and ankle with minimally invasive approach. And that's how I've tailored my practice since then.
Amazing. So I think kind of just jumping right into it, we hear this word bunion thrown around a lot in the media. You've heard it growing up. So what is a bunion first off, and how common are they?
Yeah, so very good question. I think there's a big misconception of what a bunion is. A lot of people come to the office and say, can you just trim it down? Everyone thinks of a bunion as a growth that's growing on the side of their big toe. A lot of times it creates a lot of pain in the shoe wear. People don't like the look of it. There's a lot of different reasons why patients come to the office. But I think the big thing that I spend a lot of time with my patients is trying to teach them what it is, hence your question. And it's not a growth. It's basically a deviation of the big toe where the toe actually takes a turn and diverts closer to the second toe, and it creates a larger prominence on the inside of the foot. And that creates a lot of rubbing in the footwear, some pain and swelling in that area. And a lot of times people can't get into the footwear that they want, whether they be very narrow heels or even their sports shoes or skates or ski boots if needed. Right.
And you alluded to it by mentioning footwear and some narrow footwear there. But what are the specific risk factors looking maybe on both genetic and behavioral or environmental?
Yeah, so I think the classic thing back in the day, we used to think that bunions were caused by very small, narrow, tight-fitted footwear. And I think that was before we used, decades ago and centuries ago, people used to wear really tight footwear, and we used to cram the kids into their feet to stunt their growth, to keep the toes really, really curled into the shoes, and that led to the deformities in the foot and the toes. But as we've come to realize right now, I think the biggest thing for bunions in terms of how they come about is more of a hereditary component. Mm-hmm. Sometimes we don't even actually know why it happens. It just happens with time. The footwear, I think, is a thing of the past. However, it can lead to having some more narrow or crowded toes as well.
Right.
And that's usually what is the cause, is that there's more of a hereditary component to it. And usually they're on the mother's side or father's side or even further down the lineage.
So when do patients typically seek help for these, whether it's surgical or non-surgical? When do you find someone comes in? At what point in the progression of that bunion?
Yeah, so I mean, there's different reasons. I think I get patients who come just because they don't know what it is. So they think that there's something wrong with their foot. Why is there this prominence there? And they might not even have any symptoms whatsoever. They could just don't like the look of it. So they come for cosmetic reasons. Patients don't like how it looks. They can't get into their narrow shoes, their stiletto heels, or whatever that may be. Or if, they have to expose their feet for whatever job they have, they don't like the way it looks, so they're subconscious about it as well. And then also we get patients who come who have tons of pain. So they can actually lead to a lot of pain, difficulty, walking, difficulty performing their work activities, and also in athletic populations where they can't fit into their footwear, or it causes a lot of rubbing and pain and physical limitations because of it.
Right. So do you find these injuries or this deformation of that big toe is happening more so in athletic populations who might be younger, more active versus older, say recreationally active people?
Honestly, all comers. I've had patients who are extremely young in the juvenile span of their life. Kids, I've had adolescents, there's older patients that come, there's elderly patients that come. It can happen in athletes or non-athletic populations, could be in active or non-active populations as well. I would say primarily the most common is a middle-aged woman. They're more prone to having it based on what we know. But to be honest, I've seen it all in kids, men and women, boys and girls, and an elderly population as well.
And when a patient comes into your office complaining, whether it's for a cosmetic reason or some impact on their mobility, how do you kind of guide that conversation with them, whether this is surgical or non-surgical, considering a cosmetic issue will kind of be different than something that's impacting someone's function?
Yeah, for sure. I think the biggest thing is, what's driving the patient to come to my office, right? I try to understand what is the main focus of their complaint, if there is one or not, right? Usually for cosmetic reasons, we probably would steer away from doing this procedure because surgery is it's not just anything, right? It comes with a bag of risks and benefits that we have to go over. So just to do it because they don't like the way they look is usually not an indication to proceed with surgery. Right. However, that could be still done, but that's usually not covered in by the provincial coverage for that reason.
Right.
But for the most part, I would say is if patients come with physical symptoms, limitations for their physical activity, work, or even just because they can't get into the shoes to perform their job because of the rubbing effect and because of the crowding of their toes. And a lot of times patients have other zones of pain in their feet. Not so much the bunion, because you can have other areas of your foot that are painful due to the bunion.
Right.
And that also leads us to do surgery because of that.
And in those cases where surgery is contraindicated, is this bunion reversible? Is that something that you can adjust your lifestyle or behavior to reverse that?
Yeah. So, I think the biggest discussion when a patient comes is, number one, if they have symptoms or not and what's driving to come in. And then once we've established that, we then determine, have they tried anything? Have they tried anything to try to cope with this pain or their discomfort? Have they done anything to manage it? And like anything in orthopedic surgery, there's a non-operative management and there's also a surgical management, right? The non-operative management is usually consisting of wearing a wide toe box shoe. So where we're creating a little bit more room, where the foot has room to be in and the toes have room, they're not getting that rubbing effect and they're not getting the pain because of that.
Right.
Sometimes patients do like to wear spacers or some devices or sleeves that keep the toe straighter, that they can manage it that way, that decreases the angle of the toe, which decreases the rubbing and then that swelling effect and the pain in that area as well. Orthotics have been shown to be helpful sometimes to neutralize how the foot is, how they walk, and that could alleviate some of the pain that they have as well in their foot.
Right. And then I think transitioning from that into the surgical side of things, what are the most common surgical procedures that you perform to address this bunion issue? Yeah.
So a straight up bunion, like we actually call it hallux valgus deformity. So that's where the deformity or the deviation of the big toe, where it's crowding and encroaching on the second toe, so to speak. When it's isolated to that, we could do a hallux valgus correction. But again, every foot is different, okay? Right. Every patient comes with a different set of deformities, different set of pain. So a lot of times there's associated deformities in the foot, and we have to take that in consideration. So we can't just have tunnel vision and say, okay, there we see that there's the bunion or the hallux valgus deformity, but we're not going to take into account everything else. So we have to see how a patient is standing. Do they have any flat foot deformity? Do they have any high arch deformity? Do they have hammer toes that are associated with that? And we try to encompass the whole thing to basically make sure when we're treating someone, we're taking care of all their problems so that they have a nice painless foot, but that is going to allow them to get their function back. So in terms of the bunion surgery, I think the biggest push right now is the basis of the surgery is basically to realign that big toe and to create to decrease that deviation and the angle so that the toe is nice and straight so that you get rid of that prominence. And that is basically the basis of the surgery. And there's a lot of different procedures. There's like over 100 different type of bunion procedures. I think the new wave right now is to do things in a more minimally invasive way.
Right.
I think minimally invasive surgery right now has taken over and has really taken off for foot and ankle surgery. And it's created a lot of endless opportunities for what we could do in a very slick manner, which decreases a lot of, the surgical burden, where patients don't have to have big incisions, and it allows them sometimes to be, able to return to walking right away or a very, very near after an operation, and they could regain their functional lifestyle quite quickly, and the healing is actually faster as well.
Right. That makes sense. Definitely. I know that probably puts patients' mind at ease knowing it's something that's minimally invasive. So how does the recovery from that look compared to maybe some traditional less or more invasive approaches?
Yeah, for sure. So even when I first started 7 years ago in my practice, the classic way that I was taught was a very traditional like open bunion correction, where we'd have to make a decent sized incision. Patients after the surgery, after the correction, would be non-weight bearing for 6 weeks. So they can't actually put any weight on it. You'd wait 6 weeks before they can actually put weight on it. And then the healing time would be that much longer. And all the muscles get really, really atrophied and weak. So then it takes a longer time to recover. Nowadays, when I do my bunion surgery, patients are allowed to walk on it right away, the day of the surgery if they want to. That in itself has really changed the post-op recovery and journey of a patient after a bunion surgery, where it's not so dreaded that they have to find ways to be off their foot for such a long time, or be on crutches, or use a walker for the first 6 weeks of that. Right. And then the bigger thing also, the advantage is now we don't really do any incisions, right? It's all little pokals. I usually don't even need to put a stitch. So that decreases all the swelling. It decreases all the post-op pain. And again, it doesn't have that big management of wounds and incisions that we have to manage after an operation. So that has definitely accelerated the recovery for the patient. They have less pain and swelling, which allows them to be walking on it sooner. And it allows them to get back to doing some of their things that they would like to sooner. So, I mean, all in all, I would say it's about 3 months recovery. Sometimes it can take a bit longer. Some patients have risk factors in terms of having some risk factors against bone healing or for bone healing. So those are things and factors that we take into account. But I would say it's about 3 months for the recovery and up to 6 months sometimes.
So like looking at the mechanism of what the injury is, you mentioned hallux valgus, where that big toe is kind of pointing towards the second toe. Is that mainly a bony issue with a misalignment, or are there also significant like tendinous or muscular problems that can happen with that?
That's a good question. I mean, I think bunions are very complex, okay? Everyone might think that the feet, it's just the growth of the toe, or the toe is just curling towards the other toe, and people have ugly toes and crooked toes, curly toes. There's a lot that goes on in the foot. There's a lot of ligaments. There's a lot of muscle and tendons in that area. There's a lot of force that goes to the bottom of the foot when you're standing. It's at the end of the line. At the end of the line of the body, you put 4 to 8 times your body weight in terms of load through your foot and your ankle. So it takes a lot of forces. It takes a lot of, a lot of burden and stress when you do have foot pain, and it can affect you for quite some ways. So there's a combination of all of that in terms of muscle deformity. There's a combination of the inherent joint deformity, which then changes the forces in the foot.
So, Dr. Arora, you alluded earlier to the fact that each foot is going to present differently, so you got to kind of tailor your approach. What do you find a typical patient presents with? What's kind of some common other symptoms that come along with that bunion?
Yeah, so I think that the biggest thing is someone who's symptomatic, who's coming with a problem in their foot, and it's coming from the bunion. I think the big thing is they talk about having pain in their foot. They talked about having pain in the other toes or underneath the other toes, what we call the lesser toes. The lesser toes are the toes next to the bunion. So the second toe, third toe, fourth toe, fifth toe. So you can get what's called transfer metatarsalgia. That's where a patient is actually not putting weight on the bunion that's giving them trouble and pain. And because of the deformity of the foot, of the big toe, and they start transferring their weight on the other side of the foot.
Right.
So that could be the cause of why they're coming for their pain. And then when you see that they have a bunion, it's not just tailoring the surgery to the big toe, it's about correcting the whole foot.
Right.
Sometimes they could come with secondary deformity of the smaller toes, and we have to correct those as well. Very commonly, patients come and they say that they have pain with their hammer toe of the second toe, and they say, "Can you just fix that second toe?" And then you see that they have the big toe that's curling into the second toe. And you can't just correct the second toe without taking away the big toe out of the way.
Right.
So we kind of had to tailor it to each foot, and every foot's different.
So kind of going into that, what exactly is a hammer toe? Kind of sounds something mysterious going on. What is it?
It's not something you hit a nail with. So a hammer toe is basically a deformity of the toe which curls up. And again, that's a very complex thing in the sense that the tendons tend to pull the toe, and it creates this kind of hook deformity of the toe itself. That could be a flexible deformity where you can actually straighten the toe. Sometimes it could be a fixed deformity where the toe is just stuck in that position. The longer a toe is in a flexed position, the less has tendency to move, and it can become very, very stiff. And that creates problems in itself where the top knuckle part of the toe, or we call the PIP joint, which is the knuckle of the toe itself, rubs on the footwear as well. It could create more pain in that area and increasing pressure. And that, again, could be a reason why we have to do a surgical correction to that toe. And then subsequently, sometimes the bunion, which is usually the main cause of that.
So kind of elaborating on that bunion, the fact that that joint is now articulated differently, does that change someone's complications and probability of getting arthritis in that joint, or how does that work?
Yeah, so I think the joint reaction forces that happen in the toe, when it is deviated, when you have a large deformity, it's not a well-concentric joint. So the joint isn't nice and centered and smooth.
Right.
So it's irregular shaped, and the articulation of the joint gets altered. And that eventually could lead to more wear in that joint. And then subsequently, it can lead to some, degenerative changes and arthritic changes in that joint as well.
Right. And if you notice those arthritic changes, say during your assessment or you get imaging back from the patient, will that also be addressed intraoperatively along with the bunion?
That's a bit of a complex question because when you have a bunion and an arthritic toe, those are two different problems.
Right.
The treatment for that can sometimes be different. If it's mild degenerative changes, then we could just treat the bunion to align the toe, and that could alleviate the pain or the discomfort from the arthritis or the degenerative changes in that joint. So that in itself could help. If the arthritis is too advanced, then just straightening the toe will not take away the arthritis.
Right.
That does not get reversed. So that could be a problem. Even you'd have a straight toe, but then a painful toe nonetheless. So that's where we would do a different type of procedure for that. So I think an arthritic big toe is a completely different problem, sometimes associated with a bunion, but we definitely have to tailor, again, if it's advanced, and that's where it comes with, talking to the patients.
Right. And these patients that walk into your office, is there kind of an indication when they're talking whether their symptoms are surgical versus non-surgical, or do you kind of use a combined assessment using both imaging and a clinical assessment?
I think like anything in what we do in orthopedic surgery, it does come down to, having a chat with the patient, understanding, why they're coming to see you, identifying their problem, and then we use our physical exam, our imaging, or x-rays to confirm our what we call clinical diagnosis or suspicion. And then from that, we tailor the decision in terms of how to treat them, whether it be a surgical or non-surgical approach.
Right. And in the last, say, 10 or 20 years, have there been any advancements in the technology surgically that have improved outcomes in bunion surgery, or has it maintained a kind of traditional approach as to what's already been done?
So like I said, I think that the biggest new wave of bunion surgery technique is for surgery has been the whole minimally invasive wave. And then that has taken off, and it's been going on for more than 10 years. But just now it's really reshaped how we look at foot and ankle procedures. Right. Everything, in our orthopedic world, we try to see how can we minimize incisions? How can we do things slicker? How can our surgical techniques be improved to minimize the surgical burden to the patient, which means could they have, less swelling, less pain so that they could get back to doing what they want. And I think the big thing, like I mentioned earlier, is that whole minimally invasive wave has really changed my practice. Since my first or second bunion that I did the traditional way, I started doing a more minimally invasive approach. I've never looked back. So, right. And I think my patients have been very happy with it. And I think it's there to stay. Perfect.
Looking at kind of some post-op factors, what role do you think that physical therapy place for patients, or even on the other hand, prehab, so preoperatively, can patients do anything to kind of optimize their outcomes before or following bunion correction?
So physical therapy for bunions, I'm not a huge role, right? I would say you can do physical therapy to strengthen your foot and your ankle in terms of strength and stability. I don't think there's a whole lot of, physical therapy that you're going to do to strengthen your toe per se. So I think from a post-op protocol or treatment from a non-surgical way, or even after surgery, physical therapy is not usually in my protocol.
Right.
I think it can be used to increase someone's conditioning and strength if they're trying to get back to a sport. But isolated to the bunion, I would say there's not a whole role for that.
Right.
I think footwear after surgery is a big thing. And once it's healed, trying to get back to doing their activities is a huge thing.
Right. And I know there's a lot of controversy about this in general, in the general population. I'm not sure medically what kind of literature supports it, but what are your thoughts on orthotics? Yeah,
so that's a good question. So I think there's different schools of thought, right? Some people think that it's all hocus pocus. Some people think that they're big advocates for orthotics. I do think there's a role for an orthotic, a custom orthotic that's going to be customized to someone's foot based on their weight, their foot size, their foot deformity, how much pressure and where they're having pain if they are having pain. I think there's a good value of a well-fitted custom orthotic and designed for the right problem with a focus and diagnosis. And I think it could help. I do prescribe orthotics. Not everyone benefits from them. But I think if it is done properly, there's a role for it for sure.
Right. And what are those kind of two opposing schools of thought with orthotics? Why has there been so much controversy with them?
Yeah, because I think a lot of times people think of orthotics as a custom arch support.
Right.
So a lot of times, people would just go get an orthotic without a diagnosis. So it's going somewhere to get an orthotic, but what are you getting the orthotic for?
Right.
And I think the big difference for me when a patient comes to see me, I don't just write orthotic on a prescription.
Yeah.
I try to see, why am I prescribing the orthotic? And we're trying to either correct something of the foot, offload an area of the foot. And I think those are the big things of why it could be useful. But just getting a over-the-counter shock absorber or a arch support insole, I think that's a different thing. So I think there's value if done appropriately for the right reason, with a good diagnosis and direction in terms of what you're trying to achieve with that orthotic. And I think there's value for that.
Right. And before we kind of transition into the more arthritic side of things, is there anything that was left from bunion that you feel is worth noting? Maybe some misconceptions, typical patient profile, what people are experiencing with bunions?
No, I mean, I would say it's honestly probably the most common thing I see in my office. There's tons of people who have bunions, whether they're symptomatic or not. I do see tons of it in my office. It definitely keeps me busy in the OR, but I think for the right patient, there's good value for surgery, but it's not just because you have a deformity of your toe that you need an operation.
Right.
I try to, make sure, when a patient leaves my office, they understand at least what the problem is, whether they're going to go ahead the surgical route or not. At least they'll leave educated. There is some misconceptions about what a bunion is that we kind of alluded to. But I think that because of how we do things now with the advances in our techniques, the whole post-surgical bunion correction used to be a very dreaded thing. People heard, bad stories about it takes forever to heal, tons of pain, you can't walk on it. I think that's a thing of the past. Right. And now we could get people on their feet faster with minimal pain. And I think patients are quite happy with it. Perfect.
So moving kind of towards the arthritic side now, when we think of arthritis, we normally think of the big ball and socket joints, the shoulder, the hip. Ankle's not a ball and socket, but the ankle as well. So can you kind of elaborate on what first toe arthritis is, kind of the surgical approach to address that issue?
Yeah, so I mean, the first MTP joint or metatarsal phalangeal joint is basically the ball of the big toe. That's a hinge joint. There's a lot of structures there. There's major muscles that go across that joint. There's major ligaments as well. There's a lot of forces that go through that joint as well. The degenerative changes or arthritis in that joint happens quite often, and we see it as patients get older, or if patients have led a very active lifestyle, they tend to wear out the joints like any other joint, whether it be the ankle, the knee, the hip, etc. So I think that's another area that we do see quite commonly, where you have a lot of wear and tear in the toe. That can lead to a lot of pain and swelling. And because of that, patients can have a lot of, limitations in their activities, whether it be for work, for sports, or even just day to day, because they have pain in their foot.
Right.
And there's a lot of different ways to tackle it. I'm sure you're going to have a question about that.
Yeah, I do. So yeah, just kind of going on that, I know a lot of the listeners of this podcast are either athletes or people who are recreationally active, say runners, a lot of volume and mileage per week. Just before we go into the specific procedures, what's your opinion on forefoot strikes versus midfoot when running, for example, and kind of relating that to the development of arthritis, and if there is something to that where you're increasing the forces through that big toe that might be leading to more degenerative changes, or if that's a complete myth?
No, I don't think this is a complete myth. I mean, I think the more you're striking the forefoot, the more you're going to be loading the big toe area, because that's part of your forefoot. So that could definitely lead to increasing load, which would then increase the wearing of that joint. If you're striking more of the midfoot, that you're going to get more of a midfoot load, which could then lead to more midfoot degenerative changes or arthritis. Right. I mean, there's all the kinematics and optimizing that for speed and running. That's a whole other thing. But at the end of the day, like if you are starting to develop wear and tear in that joint, you may or may not have symptoms from it, because not everyone who has arthritis on an x-ray has necessarily some pain in that area. Right. And there's different ways to manage it and tackle that. Right.
So kind of going into those, that's perfect transition. What are some of the surgical approaches in tackling that first MTP arthritis?
Yeah, well, usually first from a non-surgical, let's start with the non-surgical way, okay? Because not everyone who has it needs an operation. I think for, first MTP or big toe arthritis, patients, can benefit sometimes from an orthotic. We talked about that before. But if an orthotic is designed to offload the first MTP joint or the big toe, that could decrease the forces in that area for day-to-day work or sports or whatever the patient's doing. Right. And that could decrease the pain that they're complaining about. So a customized orthotic with that kind of design could be beneficial. Sometimes anti-inflammatories, whether it be oral medication or sometimes anti-inflammatory creams, could be useful. Right. After that, we start talking about, injections, where we could decrease the inflammation, whether it be a cortisone injection or there's hyaluronic acid injections, there's combination injections, there's even blood product injections where we take someone's blood, spin it down, and inject it as more of a natural anti-inflammatory. Right. Those are all things that can help. They do not cure the arthritis. I think that's the big thing, is we cannot reverse that arthritic change. Right. Right. Whenever there's wear that has settled in, it's there. The question is, can we, kind of put a stop to that and put like a little speed bump to that so it doesn't continue to wear? Can we offload the area? Right. But we can't just regenerate new cartilage and, reverse that process, unfortunately. Right. So yeah, you alluded to that autologous blood. Is that the platelet-rich plasma? I know that's big on the market right now. PRP, yeah. Right? So, I mean, in terms of evidence, in terms of PRP injections for the big toe arthritis, I wouldn't say that there's a lot of evidence out there specifically for that. I think the evidence on that is more in the larger joints like hip, knee, right, and shoulder. I do it in some patients when they are looking for that more natural approach, because people don't necessarily like the synthetic approach, or if they've tried it like a cortisone injection or hyaluronic acid injection already and they want to try something different. There's also a cost component to it as well. So I think being honest and giving the options to the patient and having that discussion, and that's usually how we tailor which one they might want to try. But again, none of them are usually guaranteed. So it's a one thing I would say. Right. It can help you. It's not a guarantee. If it does, great. But we just need to know that it's not going to reverse the arthritis. It's like a temporary Band-Aid that could last sometimes 4 to 6 months. Right. It can last 1 or 2 weeks. And sometimes I have some patients who get 10 to 12 months relief from it as well. Right. So yeah, there's some kind of individual variation how people are reacting to those non-surgical treatments. So for patients who aren't reacting well to PRP or anti-inflammatories and the other treatments you mentioned,
what's kind of the next step going forward with them?
Yeah. So if they're, let's say, failing those approaches or nothing's really working and they say, doc, what can we do? So I think the big thing is, what is the reason that their pain is there? Is it because of pain at rest? Is it end range pain, meaning when they go into a lunge or they do a toe off or a heel rise and they get up on their toes? Because sometimes you could get different stages of arthritis or different severity of arthritis. You get what's called hallux rigidus, where you have pain at end range, where the top of the joint is starting to wear off, and you get extra bone that starts forming, and they get a little bit of stiffness in the toe.
Right.
And that's more that end range pain. For that patient, a lot of times we could do what's called a chylectomy. A chylectomy is basically a surgery, which we do also minimally invasive. It's one little poke hole. We go and we shave down the top of the bone to create clearance where the joint can actually move more to the top and bend more freely.
Right.
So it increases the range of motion, and it takes away that end range pain that patients can sometimes complain about.
I see.
In that setting, patients sometimes have arthritis as well. If there's severe arthritis, that surgery doesn't really do a whole lot, right? Because essentially we're creating more range of motion, but they're still having the pain because of the arthritis.
Right.
So depending on the patient's severity of arthritis in the toe, sometimes we'll determine if it's something that's mild, moderate, or severe. And then from there, we could sometimes do these preliminary procedures.
Right.
So the chylectomy is a very small procedure. It takes like 15 to 20 minutes, one little poke hole under freezing in the OR. We just give some light sedation to the patient. We trim down that top of the bone. Don't even need to put a stitch. Patients could walk on it right away. 2 to 4 weeks of swelling, but overall they're quite pleased and they could get back to doing their activity.
Right.
If it's more severe, if their arthritis is more advanced, that's not going to do a whole lot. So for that, unfortunately, there was some more advanced techniques where we used to do interpositional arthroplasty. That is basically where we basically put an implant inside the toe to widen the joint and to try to give an artificial joint, so to speak. A lot of those implants have been removed and are no longer approved in Canada. They tend to fail as well, where they don't provide good longevity to the joint. And ultimately, I would say the gold standard is probably a fusion of the big toe.
Right.
And that's what is the kind of salvage procedure where you get rid of the joint, you squeeze the two bones together, all the arthritis goes away, but they get a stiff big toe, but then no pain. So there's a trade-off.
That's kind of the opposite of the milder cases where we're increasing the end range of motion in that joint. But in this case, you're removing that range of motion completely and stiffening that joint.
Yeah, well, let's just say you're a 40-year-old runner, right? Yeah. You have a bit of arthritis and you still want to run. You run marathons, you're a triathlete, and you have arthritis and you're saying, every time I push off on my stride, it hurts. You come and see me, we look over the x-rays. X-rays show some arthritis. And I say, why don't we fuse your toe? You're going to lose the motion. You won't have any pain, but your running might change.
Right.
Would you be happy with that option?
Right. Right.
And if not, and if it's something where it's milder, and we say, listen, we could do a chylectomy or do that kind of procedure where you could get that range of motion or end range pain out of the way, you could still run, and you don't need to do a fusion at this point. We could do a fusion in 10 to 15 years later. You probably would want to do that ahead of time, right?
Right.
And then the chylectomy does not get rid of the joint. So it's a joint sparing procedure. So that's the good thing about it, right? But the fusion ultimately is the surgery that we would do for severe cases of arthritis. There's different ways of doing a fusion. That is a more extensive procedure where we have to basically squeeze the two bones together, whether it be plates, screws. Those are different ways that we do the technique. But usually patients are non-weight bearing for 6 weeks after that surgery. It takes a good 3 months, sometimes longer, for it to heal.
Right. And this is kind of a broader question that's been popular in the media. The idea of cartilage regeneration and restoration. How close do you think we are to that? And if you're aware of any kind of trials that can eventually lead to changing this procedure where you're addressing that arthritis directly, is there any implication with stem cells or cartilage restoration? And how close do you think we are to that point?
I don't think we're there yet. If you know of anything happening, let me know.
Yeah.
I think that we're still ways away from that, unfortunately. I think we still don't even fully understand it all. There's so many moving parts to that to factor in.
Right.
There is, push for stem cells and all that stuff. But again, there's no guarantee of that. Costs a lot of money as well. So those are things that we have to factor in before we're offering that to our patients. But that definitely there's a lot more to explore from that end.
Right.
And we still are understanding and learning things as we go as well in terms of the science of that.
Right. And this next question doesn't have to necessarily tailor just for bunions or colectomy or the hammer toe that has been mentioned. But as a foot and ankle surgeon who sees many patients, has been practicing for years, do you think there's any gaps in the current research that you would like to see kind of more targeted efforts towards, where we're missing maybe some optimized treatments and procedures that could help patient outcomes?
I think like even for big toe arthritis, I mean, I think if we could have a procedure that we do between that chilectomy and between a fusion that does very well, that would be great, because I see a lot of patients who fit in the middle there.
Right.
There used to be, like I said, these surgeries that we used to put these implants in there. They tend to do okay, but then they end up not lasting too long. So then it just puts you in a position where you're kind of wondering, was that the best treatment for the patient, right? Or should you just skip to do the fusion or something like that? I think as we advance techniques, we're trying to figure out ways to, provide a tailored surgery that can help a patient, but not every patient has severe arthritis, let's say, or a severe bunion, right? So sometimes if there was something that we could do in between, that would be something that would be quite exciting.
Right.
But I don't think we've found that yet.
Right. And are there any particular signs or symptoms when a patient walks in that you think would prompt them to seek care either surgically or non-surgically sooner rather than later?
I think, like I said, the big thing is if they're having pain and limitations, that's a good time to explore maybe seeing someone, especially if they've tried different things in terms of like a non-surgical management. That's where the surgery has a role, right? Let's say, if we're talking about arthritis, they've tried orthotics, they had an injection, it doesn't work. Well, that's definitely where the surgeon could, play a part in guiding a patient in terms of their management and treatment. And that's usually where we come in.
Right. And in these procedures to address the bunion or the chilectomy, are there differences in the surgical approach you take between younger versus older patients?
To be honest, no. Well, yes and no. I mean, I think, like I said, for me, my bunion surgeries, if I could do it minimally invasive, I will do that every single time, because I think the outcomes are way better, not only in my hands, but I see it in my patients. They're way happier. They're happy that they could be weight bearing right away. They're happy that they don't have all the inflammation and swelling and post-op pain. So from the bunion side of things, right. 100%. For the big toe arthritis, I think when we're talking about the chilectomy, the traditional way of doing it, we used to do an incision. We used to open up the joint to trim out that bone at the top of the big toe.
Right.
Now, if we don't have to do the incision, we could do it pretty slick through little poke holes. That in itself has changed everything, because patients don't have all the swelling, they don't have all the pain, and they could get back to walking right away.
Right.
So for me, if I could do a surgery minimally invasive and have the same outcome, I would do that every single time. And right. I think the patients are happy about that, and they would choose that and appreciate that every single time as well.
So as someone who has done many of these surgeries, and patients come into your office with pain, complaints about limited mobility, limited function, is there any story that comes to mind, some memorable patient story where bunion surgery significantly changed their quality of life? Any kind of specific examples?
Yeah, actually, I just saw on Friday, I saw a patient who had done her left foot bunion correction. I think it was 8 months ago.
Right.
And then she was really thrilled and happy about it. And she had the same problem on the other foot, on her right foot. And she just had her right foot done probably about 2 months ago. I just saw her in clinic last week, and she was so thrilled that her pain was gone. She was extremely excited to be able to go back to running. She was a big runner,
right.
And she was unable to run because of the pain in her bunions, because of the rubbing in her shoes. And she is thrilled and excited that I was able to give her the pain-free foot and feet that she has to return back to all her activities, primarily running, which was her, passion sport.
Right.
And I think, for me, that's the biggest thing, right? If I could get a patient back to doing what they love and get them out of pain and discomfort, I think for me, that's the value in what I do. And that's quite humbling as a surgeon. And I think, that's why we do what we do.
Amazing. So where do you see this field heading in the next say, decade. Do you think there are any advancements that need to be made to improve, optimize these procedures where patients might be currently, I'll rephrase that. Do you think there's anything that can be done in the next 10 years, research-wise in the medical literature, that can improve patient outcomes if it's not optimized already and you're not happy with the current state of the field?
I think we're always trying to push the limits and improve our surgical techniques, right? And I think in the world of medicine, it's not a static field, right? There's always evolution, there's always changes. As we learn more and do more research, we understand more. And then as we try to do that, we try to improve those surgical techniques and tailor them. So there's also the advancements of techniques, but there's also tailoring certain techniques for the specific patient.
Right.
Because not everyone is the same. So I think combining all those factors and getting a better understanding of the patient and their problem and being able to tailor a treatment that's specific to them to get them back to whatever their goals are, I think that's the ultimate goal for us.
Perfect. And Dr. Arora, you provided a lot of insight today into foot and ankle surgery, bunions, kylectomy, hammer toe. We've covered quite a bit. Are there any kind of closing words, anything we haven't mentioned today that you'd like to put out there to the Pathway podcast world?
Yeah, no, I think it's exciting. This is a great venture that we're doing here. I'm happy to be on board. I think there's a lot more that we could do. There's tons of people that are waiting to be seen and to get back to doing what they want to do. And I'm just happy to be there to be able to provide that for them. Perfect.
With that, thank you, Dr. Danny Arora, for joining us today on episode 2, all about foot and ankle and bunions as well.
It's been a pleasure. Thanks for having me.
Thank you very much.